Good afternoon, everyone. There's a few folks in the room. There's a few folks online. Happy that you guys have chosen to be here today. And we've got a good number of things to try to walk through today. And most of it is centered around the 1115 waiver and what are some readiness considerations to bring to the table. And Care Compass, we've been spending a lot of time looking at what does the waiver say, or maybe I should back up. The waiver, it's been released in concept, but we really don't know a lot of things yet. There's a program manual that's outstanding. The state is still going through this review cycle, and yet there's a lot that we do know. And so we've looked at this to say, given what we see in the RFA, given what we've seen from the last waiver, given what we've seen from other programs and initiatives that we've done, what are some of the insights that we can maybe give out there to prompt you as leaders within your organizations to think about how can we prepare ourselves to be ready for this new waiver as it prepares to launch later this summer. So we have some recommendations and some considerations. Some of these are going to hit home and you'll say, that's really great. I'm going to make a note of that. Some of these might not be right for your organization, but we're trying to cover a wide span of different things to sort of prompt thinking for waiver readiness. It seems like this presentation, you can go to the next slide, Alexa. We'll be able to cover maybe a few updates that you haven't heard before, and also be able to cover in some considerations around the factors that you mentioned, like business planning and things along those lines. Before I get into the main topic of this presentation and discussion, which is waiver readiness, I wanted to share something on the workforce investment organizations. It's not something we've seen any sort of formal release on from the state, but this waiver is much, much more than just social care networks. There's also workforce investment organizations. There's healthcare, or health equity regional organizations, the HEROES. And in some of the back channels where I've been, talking to different organizations across the state, I've come across a framework for the regions that I wanted to share with you today. This is informal. This is not published by DOH. This is just the current rumor mill from across the state, seeing how things are taking shape. So I wanted to call this out here with a highlight in the red highlight in particular is the counties that Care Compass has typically served over the course of the past few years. And how this is important is the workforce investment organizations will be coming up with investments to support recruitment, retention, hiring of certain positions, mostly clinical based, but CHWs are a part of their approved panel of positions to support. The state has said through the RFA that they will break up the state into 3 regions, and that up to 3 wheels will serve those 3 regions. So we've not seen the designation yet, nor how that designation process is going to happen. But if you as a community leader span these regions or whatever ends up being the final regional breakout, that's going to be important to know, because maybe the WEO that's serving region 2, maybe they're going to fill funding or assigned funding based on a formal application process, and you're going to want to sign up for their newsletter and be alert to how that process is going to work, because it may not necessarily line up with the same model that the WEO that's serving region 3 does. So we're looking at social care networks and the Southern Tier region, the Finger Lakes region, the Central New York region for most organizations in this room, and is a completely different regional breakout from a workforce investment organization perspective. So I wanted to share that with you today. Again, these are just spitballing things on a wall. They're really not a perfect science, but from some of the conversations we're having, this is how some are starting to see the landscape. So I wanted to share it. I think the high level takeaway is that there will be 3 regions. And when those 3 regions come out, you're going to want to get connected with the WEO or WEOs that serves the counties that you serve. We will be making that available to you. We're trying our best to keep a read on how these things are playing out. So if a certain organization is serving 2 of these wheels or individual ones, we'll make sure to make it easy for you to find out. Here's their contact information. Here's how you sign up for your newsletters. We'll try to make it easy for you to engage in that side of it. But that's as much as the update that we have on the WEO side of things for today. We actually have 0 update on the HERO. There's really been nothing from the state that we've heard about. There's, passively, they want to have the HEROES getting started later this year. But a lot of the updates have really been on the social care network side of things. So Before I dig into and get lost in social care network updates, wanted to share a little bit about what we've seen from the WEO side of things. I will give a quick pause because we do not have a crystal ball, and we have not had direct communications on any of this. So if anybody in the room or online has had WEO updates or even HERO updates that you want to share with the group, certainly feel free to unmute and add those updates to the conversation. All right, well, we'll take that in stride. Next slide, Alexa. So we'll bring more on the WEOs as we hear more. Before I dig into best practices in social care networks, just wanted to give a high-level update, timing, where are things at? You may have been outside of the loop for a period of time. We're now officially in this window of time that the state has referred to earlier this year with when they would be making announcements on the awarded social care networks. And that window has been described roughly as June or July. So by default, we're now in June. The state could at some point in time be making awards on social care networks. As soon as they make awards, there's several key steps that are worth just understanding. One is there's going to be a notice of awards. Following that, there's going to be a social care network and New York State DOH contracting process. Once that's completed, you'll presumably see the state being able to release infrastructure funds to the social care network. Roughly speaking, if the state is going to make awards in June or July, I could see those three steps happening in maybe the July-August timeframe. Again, just assigning reasonable steps to contracting and mapping some of those things out. Maybe it's aggressive to say July or August, but that's just an approximation. After the social care networks have finished contracting with the state, I could then see the social care networks contracting with their CBO network. There's maybe going to be terms in the DOH contract the social care network is going to have to consider before they finalize their contracts with their CBO network. So I would see that as a concurrent thing or happening shortly after the state contracting is completed. And then there's going to be each social care network is going to have some way of distributing infrastructure funds. And I have to presume there's going to be some kind of application process or RFP process for identifying who's interested, what are the services they offer, and all those kinds of things. So very aggressively, I could see as soon as an SCN has contracted with their CBO network, one of the very early tasks is going to be deploying infrastructure funds. And their methodology of doing that would very likely come out in close proximity to the CBO contracting process. And all of those steps being completed, leads to the release of those early infrastructure funds. And again, I just roughly bucketing timeframes. Maybe that's an August to October timeframe to build the contracting, release any sort of RFPs, gauge interest on who's interested in expanding what services and things like that, and then beginning to release the funding. So these are all approximations, but I think you can follow, the rough timeline here. So given these, a few goals for today with this report out. One, we really want to know what does the waiver say and what's yet to be released. For those of you online, there was a lot of heads nodding when we're talking about the program manual, our present that we're hoping to get from the state sometime soon. We also want to evaluate what can reasonably be started now versus what needs to happen, but we have to hold for some specific reason until later. And also consider what factors impact readiness considerations for your organization. So Alexa, you can jump to the next slide. All right, and one more. Okay, so this is sort of outlined as step 1 and step 2, and this language is directly from the RFA. And I'll take a moment to read on it because there's a lot to unpack from this on the next few pages. Step 1 is HRSN screening, and out from that is a navigation of services. But on the first step, which is where we're going to focus today, the social care network lead entities will coordinate with CBOs in their network and other partners in the regional ecosystem, being healthcare providers, care management providers, and MCOs, to screen each Medicaid member in their region at least annually using a standardized screening tool. And some of you reported earlier already using this tool, but there is a standardized tool that the state's releasing for purposes of this waiver. And the lead entities will be accountable for tracking the results of the screens through their data and IT platforms. You can see step 2, and this gets to be very workflow specific. We're not going to dig into this today. This could be a completely separate topic, but it then goes on to say that the lead entities will be accountable to the state for navigating eligible members to appropriate social care services. So the sort of out of the gate principle is that we're going to be doing a bunch of HRSN screens, and then out of that, making referrals. And it's the social care network that's going to have an accountability, not just that the screen was done and the referral was done, but that there's a navigation and a closed loop process to all these different activities that are going on. Again, I'm not going to focus on the navigation to services component today. That's where we get really, really workflow heavy, but I just want to focus in on this first step, which is the HRSN screening. So, and we'll make these slides available at the end of the meeting. So if you're grabbing notes, we'll make this available to you. Alexa, you can go to the next page. So there is a predefined screening tool, standardized, and we'll show you what that is in just a few slides. But in addition to the questions that are on that screening tool, there's other pieces to screening, so to say, that the state mandates must be done. And so I want to just outline some of these here, and maybe this can start to help you think about, do I do this today? How would I be able to do this with my system? Or even note to yourself, hey, I don't do this today, and I'm going to have to make sure the social care network is aware of that, because I may need some support in getting ready. But the first one is member contact information, including name, current address, and phone number, along with an email if it's available. Basic data about a member's identity, which includes but not limited to name, location, race, ethnicity, age, physical disabilities, and sexual orientation and gender identity, SOGI. Confirmation of a member's desire to receive social care services. They could screen positively, but may decline a referral to a service. The approach, I'll call it a cultural competency approach in prior terms, but the approach must be taken in accordance with national standards for culturally and linguistically appropriate services. They're referred to as the CLAS service standards. They must be available in multiple modalities and languages, potentially not within a singular organization's umbrella, but across the region. We have to have multiple modalities and languages. And there's specific language in the waiver, and these are all quotes from the RFA. So this isn't like Mark wrote a nice summary. These are actual just statements from the RFA itself. CBOs may screen members, but cannot be reimbursed without using a standardized screening tool. And then there's also, we'll get into the multiple domains and then other notes that might be appropriate for completion of navigation services. Kayla, you can go, or Alexa, you can go to the next slide. You guys can't do this here, it's not fair. Okay, so again, the RFA also states CBOs in the network can conduct screenings and must meet the following criteria. A CBO must make a designated point person for screening members. A CBO must have the capacity to conduct in-person and telephone, virtual, website, and text messaging screens. So that on our end is something that we're researching to see, hey, if somebody can do in-person and telephonic, but not text messaging screens, could they still participate? It's a question that we have. We want to investigate it, but as currently written, the waiver outlines that these are sort of the requirements to be able to perform the screens. The CBO must also be willing to receive trainings on screening members with HRSN or for HRSN with cultural and linguistic competency. It's the CLAS standards that were on the prior slide. That's more specific to the CBOs. There's this whole other side of accountability and work that the social care networks must do. And the first one here is that the social care network has a responsibility to provide a public-facing website that enables a member access to or information on where they can be screened and referred to social care services and relevant contact information for each location. So in the case of Care Compass, if we were awarded social care network role, one of the first things we would ask organizations that are doing the screens is, what's the appropriate address we would give people? We have to put this on our website. Could we get a disclaimer to put this on our website? All those kinds of things. But this is a big difference from district where, at least from our perspective, Care Compass wasn't providing any services. We were sort of pushing the Medicaid members to the direct service providers out in the community. But in this case, the social care network must maintain a website that communicates all this information as well. So apologize in advance for any survey fatigue, but any and all social care networks are going to be interested to get this information. And I have to imagine they'll use surveys, but they have to have that as an accountability measure to the state for their website. And I won't go through all the other features, but you can see language, translation options and things along those lines. Alexa, we can go to the next page. Okay, so this is, and I'm not going to read this one line by line, but this is the actual screen. So what the state did was they took an existing screening tool and they've modified it down. And I want to say there are 12 different questions, but I'll give a moment just for you to read and see this. And again, this is on our website today. So if you wanted to just look at this offline, this is an attachment to the RFA. And it's also in this packet, but if you want to have a chance to see it, when the state says there's going to be a standardized screen, they published it, it's out there, you can see the questions, you can see the sub questions and answers underneath it. It is organized by domains. You have housing and utilities, food security, transportation, and so on. And so where I get into the workflow side of it that I'm not going to get into today, you could take any one of these questions and say, okay, if there's a successful series of answers, how do I make referrals based off of that? Who are the referring organizations for some of the answers that might be given into this? And that's a completely separate workflow. But for today, just looking at how can my organization be best prepared, the question is, this is the standardized tool that's out there, and this is sort of one of the initial programs that's sort of at the precipice of starting the work. It's how can we do these screens, and then from here move on and do the referrals. So I'll pause here. I don't know if anybody's using this tool today or has integrated it into their work or had any experience at all. I'm happy to keep going on too. Yeah. No. Yeah, I think some of the earlier questions or some of the earlier survey responses was, I'm using it, I don't expect any difficulty, or the other one was, I'm already using a tool, I don't expect a difficulty. One of the technical questions that we're looking at with the state is, what if I use a different screening tool that has some aspects of it? Do I have to completely change, or can I pull those questions into and integrate that to the social care network? So I know that's a question some have had that we're looking for an answer for. And that's on our radar. Okay. So let's jump to the next slide, Alexa. In terms of readiness, one more. Yeah, I don't want to read through all of these. One thing that a lot of our CBO partners that we've talked to have started to think about is, what's the ramp up cycle in terms of getting ready for the waiver from a screening perspective? And some of it is, I might have existing resources or I might have to do a new hire, but how do I prepare those positions? And items 1 and 2 here are really some of the main startup elements. So you get into identifying your resources internally. How do I complete some of the training and onboard them to the closed loop referral system or some of the other IT platforms the social care network might be using? And all of that is non-reimbursable startup activities that potentially the social care network might offer some startup funding for. So the social care networks have funding for initial investments. It's called infrastructure funding. And those could help, depending on the social care network and what their plans were that they submitted to the state, that can cover things potentially including training, onboarding, hiring, even staffing salaries for a set period of time. Outside of that, as you look at the break even, that's where we get into the costing. And that was one of the main concern points for people in the survey earlier, which is, what's the state going to pay for this? how many of these activities can my resource actually perform, and can that happen in a way that balances the scales to where we can break even with that resource? And it's a question I can't answer for you today, but that's one of the pieces that's in the program manual that I mentioned earlier, which is the pricing information for these interventions. So I would, within the RFA that was responded to, there was an infrastructure budget, and the social care networks will be limited in distribution of infrastructure funding to what they wrote in that application, unless they get into petitions to the state to reassign budget categories and things like that. So some of you might be participating in Southern Tier, Central New York, Finger Lakes. One of the early questions that if I was in your shoes, would want to ask the social care network is, what is startup funding for a social care navigator position? How can I apply for that? And how long does it cover that staffing for? The infrastructure funds, I'll make this up. Bob might have a better answer for me. And that they're 95% consumed within the first 2 years. Bob, I don't know if that's a fair estimate.
Well, I mean, it's 90, but you know what, 90, 95, it's rounding error at that point. But it is about 90% gone in the first 2 years. And the first year isn't even a full year. It's just the period that ends March 31st. So really, 90% of the infrastructure funds are gone within probably 19 months.
Yeah. So that's helpful to think about, because yes, there's going to be startup funding, but the window of time to go from what's here is 1 and 2, but just onboarding and preparing your staff, even if provided some funding from the social care network, it's only really going to cover a 19-month period, because that last year it's a big cliff in terms of the amount of funding that's deployed in year 3. And just in terms of talking about years, it's in the footnote here, but these are New York State fiscal years. So right now, even though no work has started, no awards have been made, we're in the first year of the waiver. The first year will end March of 25. The second year will commence April of 25 and go on for the next 12 months thereafter. So at least for now, when we're saying year 1 and year 2, year 1, we're referring to, whenever these things come out, sometime in the next few months through March of next year, and year 2 being the following period after that. All right, the next one, this is one that we want to pay a lot of attention to. So this is the social care network service areas. And right now, it's easy for us to pull out data on a regional level, but we don't yet have information on a county by county level based on attribution. But this gives us at least a high level view. For this discussion, we focus just on three of the regions, because that's where most of you represent. The Southern Tier, the Finger Lakes, and the Central New York regions. But ideally, we could say, from Central New York, here's the population of Cortland County, or from Finger Lakes, here's Steuben County. But at least at a very high level, you can see here the layout, because there's a requirement where maybe you want to expand services to target the enhanced services in a part of your community. Well, the question would be, what population is eligible to receive the enhanced services in those communities? And this starts to give you a little bit of the breakout by each of these regions. Bob, if it's okay, I didn't give you pre-notice, but since you helped pull all these facts together, do you want to walk through how the step down works for each of these regions?
Sure, I'd be happy to. Hello, everyone. So the way that each of these sets of numbers is derived such that each line below is a subset of the number above it. And so we have here the Southern Tier. And so in the Southern Tier, to the 6 counties that New York State designated as the Southern Tier region, there are approximately 138,000 Medicaid members. Of those 138,000, 97,000 of them are on managed Medicaid, which is about 70%, which means that about 41,000 Medicaid members are straight Medicaid fee-for-service. And so of the 97,000 that are on managed Medicaid, 63.6 thousand of them, or 65%, are eligible for the enhanced services. As a reminder, the Medicaid fee-for-service population is not eligible for the enhanced services. They are only eligible for screening and referral navigation. And so that's why we concern ourselves as we narrow down this. We concern ourselves with the eligible population within the managed population, and so we have that 63.6 thousand eligible for enhanced services, and then also the state provided information such that they were able to quantify the number of individuals within the eligible for enhanced services population that also have behavioral health and or substance use disorder conditions. And that number for the southern tier is 42.1 thousand or 66%. And so, the numbers here will vary across the southern tier, Finger Lakes and central New York region. But one thing that I thought was interesting as I went through this exercise in preparing all of the numbers was that by and large, the percentages are basically the same. It's roughly 70% of the population across all three regions that is managed Medicaid. It's roughly 66, 67% of the population of the managed Medicaid population that is eligible for enhanced services. And of the population that's eligible for enhanced services, 67% or so have behavioral health and SUD and or SUD conditions. It just shows that even across all three regions, such things that we know like most of us are in the southern tier and a portion of the Finger Lakes and a bit in Cortland. And we know that behavioral health and SUD are prevalent across all of our service areas. And what this shows us is that it's not any different anywhere else in the neighboring upstate regions. And then obviously the scope down, if you will, that I went through for the southern tier also is there for the Finger Lakes and the central New York. And it is unfortunate that we don't have the county level numbers because obviously that would be more operationally helpful for the organizations that are on the call. But this is what the state gave us. Back to you, Mark.
Directionally speaking, the higher level number, so 138,000 members in the southern tier, 450,000 in the Finger Lakes region. The state's goal is that all of them have one of those health-related screens performed each year. That's sort of one of the aspirations of the waiver. Outside of that, they want to, for those that qualify, deliver the enhanced services. And so just roughly speaking, you could say, hey, in the southern tier, about half are eligible for the enhanced services. It's not exactly that, but even in the Finger Lakes region, 215,000 out of the 450,000 are eligible. So, I mean, it's hard to tell who's managed Medicaid or fee for service within your own clientele list, but at a regional level, it's roughly half of them that are eligible for the enhanced services. So just at a high level directional figure, it's only those enhanced services that are, reimbursable. All of the screens are reimbursable at an unknown to be published rate, but roughly about half of the regional population is eligible for the enhanced services based on the period of time the state did this, which I have to presume is, a calendar year of the prior year. Okay, so we'll keep moving forward. I'm pushed to maybe finish in 5 or 7 minutes here, so I'll try to go quicker through these last few slides. Again, these will all come out. A few key notes on this slide. This is just the administrative side of it, and I'll cover a little bit on the documentation side. In looking at this waiver, this is a waiver where the CBOs will be invoicing, so to say, or doing work for and being paid by the social care network. And the social care network is distributing and receiving payment from New York State. This is a Medicaid billable activity. And so one of the documentation standards is going to be, did the service that was provided meet the service standards? And so as we look at the program manual, there might be certain documentation standards that the state sets out that we'll have to make sure are met as the social care network is distributing funds for the services. It's not uncommon with a Medicaid reimbursable activity, and we haven't seen this yet here, we're just sort of reading the tea leaves. They might start to ask, like, not just was a service performed, but who specifically provided that service? What was the date and time of the service that was provided? And so we're starting to call out some of these aspects because this gets into what data is or is not going to be required. On district purposes, it was, here's a roster of everybody that we navigated this month. Here's my attestation letter, and we issued payment on that basis. This waiver might be a little bit different because it might not be enough just to say I navigated, this person this month, but it might be on this date and by this staff person. Again, subject to final review of the program manual, but we're just starting to look at what are documentation standards common with a Medicaid billable service. Administratively, you can see in here, was the staff delivering the service qualified to deliver the service? We have yet to see education standards or training requirements for certain positions, but that might be something that comes into play. Another piece of it is there's a certain magnitude of rigidity when administering a state program. In district, the PPS has had a lot of latitude. Hey, data submissions 6 months after the date of service, no problem. We're happy to pay those and support you as an organization with the work that you've done. Sometimes the state might have more prescribed timeliness considerations. Maybe the date of service, you must submit it within 60 days. I'm making that up, but we might see a certain magnitude of rigidity with how the programs are managed. Also, in district, Care Compass was audited by the state annually. We had to go through the state reviews. We've got no indication yet of how they're going to handle that with this new waiver. Potentially the social care networks are audited. Potentially there's site audits that come down to CBO locations. And sort of the guiding principle from a Medicaid perspective is if it's not documented, it never happened. And so if you're submitting for something or being reimbursed for something, you don't have sufficient documentation. That's when the state likes to use words like clawback and those not so friendly terms. But that's where the social care network would work to make sure that they firmly know what are the documentation standards and train the partners as they onboard to make sure that we can avoid all of those kinds of situations up front. So again, I'm not going to read through all of these, but these are just some guiding principles and things that might come out as we start to see readiness considerations and more coming out from the program manual. Alexa, you can go to the next slide. And this is going to touch again on managed Medicaid versus fee-for-service, which is what Bob was talking about. And these are some quotes directly from the RFA. The social care network leads will use funding provided to them in the form of a per member per month payment to reimburse CBOs for their work of the managed care members and enhanced services delivered. And so in this bucket, we're saying for managed Medicaid, the social care networks will have a bucket of funds and will be able to distribute those out. Secondarily, the second bullet point here says the social care network will submit claims for the screening and navigation of the fee-for-service population. And again, you may not know when you're seeing a client if they have managed Medicaid or fee-for-service. You're still going to screen them regardless. But our takeaway is that we could find ourselves in a situation where if you did a screen on 10 people this month, the social care network, let's say 5 of them were managed Medicaid, 5 of them were fee-for-service, the social care network could reasonably pay within a very abbreviated period of time the work that you had done on the managed Medicaid population. But the social care network will be in a position of needing to bill New York State, be paid, and then pass that payment back along to the CBO to reimburse for the fee-for-service population. And it's difficult to anticipate what that mix is for everybody. I know on the prior slide, it was roughly half of each of those regional communities was fee-for-service versus managed Medicaid. But in terms of planning and readiness, this is just, I think, a concept for everybody to be aware of. And you're planning for a position, and obviously timeliness of cash flows and other considerations. So it's on our minds. We're thinking about it. We're trying to think if we were awarded social care network, how can we support organizations with timely cash flow? But just as a general principle, it's something to be aware of too, especially with roughly half the community, being in that bucket. It's helpful to be aware of. Alexa, we can go to the next slide. I know Dina's itching to go. Yeah, so these are other timing of payments and other cost planning considerations. We put in here some of the quotes right back to the RFA if you wanted to check them out. I won't read through each of these directly, but there are a few key takeaways. One of the key takeaways is that many of you might span multiple social care network regions. And the state is saying that they're going to assign different rate schedules per region. And so it's going to be important, and you're planning to also understand as soon as those social care networks know their rate schedule, to pay attention to that. I have to assume they're going to be reasonably similar, but technically they won't exactly be the same. So that's another concept to be aware of, that you could have one location with one social care navigator, let's say it's in the southern tier, being reimbursed at a rate different than a social care navigator in the Finger Lakes region. And just for, or you could have somebody spanning two regions. And so you might just need to be aware of that also for your planning purposes. The second takeaway point is that these rates are defined by New York State, and there's not a lot of flexibility on them. In district, we had a lot of flexibility to say, here's a sign-on bonus, or it's been a full year, let's review this rate schedule and see if it makes sense. And in some cases, we increased our rates after the first year of district. This is out of any social care network's hands. This is the state prescribing a rate schedule, and so there's much less flexibility with it. The benefit is that it's sort of a normalized process across the state, but we are sort of being handed a program here, and there's less flexibility from the SCNs to sort of navigate on the payment schedules. And Alexa, I think I've got one last slide, and these are more administrative. So again, we'll hand out the slides and leave these to you, but these are just some general calls to action. One of them is that all the social care network infrastructure, a lot of it might be in place across the state, but the functionality of it is new. And what they're asking us to do and the call for it is very specific. There's going to be need for governance members. There's going to be need for a lot of advisement from the community organizations to feedback and let the SCNs know what's happening, what's the best beat on the street. And surveys are very, very limiting. Sometimes it's direct phone calls, it's direct messages. They're really, really invaluable. So I just encourage, all of you here, to the degree that you have capacity to serve on a board or serve on a planning committee, or even just share your firsthand knowledge of how things are working in your community or with your clientele, to please share that, because it is massively invaluable. It's highly complex work organizing all this stuff, and your voices really matter and go a long way. So I just encourage you to review that. Another one I'll specifically call out before I hand back to Alexa and Dina is that some of these programs might be funded by the social care networks, but might also be subject to other New York State regulations. So maybe you get funding to build a new building, like a medical respite facility, or expand into a different community. That's also going to require potential other certification or endorsement from whatever community or regular agency you're working with. So we have yet to roll into that, but we've not seen waivers yet like we did see in district. In district, there was waivers where if we wanted to integrate primary care and behavioral health, the state gave us waivers, and we were able to avoid certain layers of legislation and governance. In this realm, we've not yet seen how some of those waivers might work, or other new waivers might work. So that's just another plug out there about things that we're thinking about. So again, we're right near time. I'm going to press Dina to give a Unite Us report out in the next few minutes here. But thank you so much for letting me speed my way through a few of these readiness slides, and I'll hand off to you, Dina.
Thanks, Mark. Hi, everyone. I'm Dina Hodges. I'm an IT program manager at Care Compass Network, and I am the lead on the Unite Us implementation. Next slide, please. I just wanted to walk you through things that we have accomplished so far since the contracts were signed. We have had our pre-kickoff meeting. The project teams have been established, myself as the project lead. We have developed a charter, and I have also developed a smaller work group that is mainly the SIP leads, so that we can plan for the onboarding of partners with the social impact pilot program and the Stitch partners. To do workflow planning to see how the current workflows are going to transition into the Unite Us system. Excuse me. We have completed our kickoff meeting with Unitas, the official kickoff meeting in the middle of May last month. And we are also planning, along with Unitas, to get the CCN staff trained and also the partners trained as well on the system. Next slide, please. So this is just a tentative timeline of the implementation. We've been working on the partner engagement strategy with the SIP network partners. We're in the process of getting some meetings scheduled on the calendar. We also are getting access, or we have access to the Unitas LMS training and demo environment. And we're currently starting our LMS training. And like I had said, we're trying to get a meeting scheduled on the books with the SIP Network 2 partners. And we also want to do some discovery with SIP partners that are currently utilizing Unitas. After that, in July, second week of July through the fourth week or third week, we will be preparing for onboarding and configuration of those partners that would like to adopt Unitas for the closed loop referral system, and continue the engagement with partners that are open network partners, but are also receiving referrals from the SIP network that are not contracted in the SIP network, so that we can close that loop with the referrals with them as well. And then the end of July through the middle of August, we will be onboarding and training those partners that wish to adopt the system. And our tentative go live date is August 29th. So that is my update on the Unitas closed loop referral system. I am happy to take any questions if anyone has any. Okay, well, thank you. And I look forward to working with you on this project.
I think, so that, I'm unmuted, right, Alexa? All right, so that wraps up our content for today. We're just nearing the end of the hour, but we do have some time to take some questions on the waiver. Here's some updates, some requested topics for future meetings, as well as feedback on the Unitas implementation. So just to spot check with the group, any questions or comments, happy to do so right now. Yeah.
Is there a cost associated with the closed loop referral system that you're referencing?
That's a great question. I was going to repeat the question, but I think everybody in the room could hear you. Online, yeah, so there was a question in the room. I tend to shout when I speak, so they asked me to repeat all the questions. Was if there's a cost associated with the Unitas system, and the short answer is no. CareCompass Network has acquired that to support its programs and initiatives across the service area that it serves, which is the 9-county region that we serve for district purposes. So if your organization serves Medicaid members in those 9 counties, doesn't necessarily need to 100% domicile in that region, but if you serve Medicaid members in the Southern Tier region, you could receive the Unitas system through CareCompass Network. We're starting with active partners in existing programs and sort of testing out the use cases with live programs. And so some organizations received a notice earlier today, actually, about the outreach to start the pilot or get some lessons learned. But if you do have an interest in adopting Unitas and you didn't get that message, please reach out to our team. We'd love to be in contact with you and talk to you about it. Separately from that, that's just for CareCompass programs and support. We also did apply to be the social care network. And if we are awarded the social care network, that's the system that we would also support out in the community. But since we also have a lot of other projects and programs going on, we're not waiting for the waiver, so we are offering those through CCN right now as well. Okay. Okay, well, thank you so much. We are, almost right at the 1 hour mark. We like to honor the time frame and the time that you all have set aside. So thank you so much for joining us today. We will reach out to you as soon as we hear more about the waiver. I can say in Grants Gateway, our application, we did see a status change this past week, indicating that it's in review. So it's not quite done yet. We're sort of anticipating maybe end of June, maybe early to mid-July. Still within that state window of June or July, but as soon as we get that, that's helpful to share. But really the piece that we're interested in is that program manual that has a lot of the operational questions. So as soon as we hear more, we'll be sure to let you know. We'll still be positioning ourselves to support you no matter what social care network region you're in. We want to make sure you're connected to the WEO. We want to make sure that you're connected and asking the right questions with the social care network or networks plural that you end up working with. So we're going to continue to support you along that journey. But for right now, we'll call it a wrap for our early June meeting, and we look forward to seeing you throughout the summer. Take care, everyone.